like to welcome you all on behalf of our hospital for attending this CME. I thank you all for having made it today in spite of it being a Sunday. In fact, even we have organized the CME after a very long time. So we would love to hear your feedback too. At the end of the CME, we'll be giving you all a feedback form where you can fill up whatever you feel, because in future we want to make this as a regular program, a more interactive one and a more open one. And we would be glad if, even if you're interested to make any speech or give a talk on CME, you can also, put a yes for that question, so that it can be more interactive and we can share more discussions in future. We look forward to conducting more such CMEs and more numbers in the future too. From now on, Mr. Ratnam will take over the CME, and I hope you all enjoy the function. Thanks.
I am Dr. M. Archit Krishna, consultant pulmonologist at Rajarajeswari Hospital for the past 1.5 years, and I will be talking on how to look at this most commonly used screening tool in our everyday OP practice, the chest X-ray. I will kick off with a short anecdote. A 54-year-old male smoker with cough, dyspnea and loss of weight and appetite with clubbing was referred as a case of COPD, query PTB, query CA lung with a chest X-ray done outside. The X-ray showed a left upper zone opacity suggestive of some mass in the upper mediastinum or lung with minimal right pleural effusion, along with signs of hyperinflation which was suggestive of COPD. But when I went to examine the patient, there was this big lipoma of the left clavicle. He was icteric and dilated veins were seen over his abdomen. On further evaluation, he was found to have an advanced stage gallbladder mass. This is an example of how a chest X-ray has the potential to mislead one if not read with care and correlated clinically. As our teaching methods always tell us, history and clinical examination always go first. Whenever we hold a chest X-ray in our hand, any X-ray for that matter, the desired result can be achieved only upon answering a few questions. First, the why. The history and clinical or other indication for the X-ray should be running on your mind while viewing it. When? The date of the X-ray, the timing of the X-ray. For example, pre and post procedure X-rays will be done on the same day, and certain conditions like pneumothorax, which can develop over time, which may be normal at the first view and may show on repeat X-rays. The where. By where I don't mean the place of the scan center obviously, but the localization of the symptoms, like the site and the exact location of the symptoms. Like in pleuritic pain, patients may point at the particular spot, or in injuries to chest where a particular rib may be fractured. It will help us to diagnose faster, as a chest X-ray has so many components like all these which can be seen for hours together. The how. It is to consider and take into account the technical aspects of the image. The other stuff we can even read and learn and interpret, but all these projection, that is PA or AP, angulation, rotation, penetration and degree of inspiration, are always under control of the radiographer and patient's cooperation. Only with all these will we come to the what, that is the findings. We'll go into how to read all those. Firstly, it is let us take a simple view at this. The normal lung field has a black background which is filled with air. With white colored vessels running into it. Plus there will be anatomical fissures like horizontal fissure or azygos fissure in anatomical anomalies, and the skeleton, that is ribs and scapula, will be present. Anything else apart from this would be a finding. Coming to the black lung. The lung fields appear more radiolucent. I hope you are able to see the X-rays. the lung fields appear more radiolucent or blacker when it has more air than usual. That is in a commonly condition we see, which is COPD. This is a typical X-ray of a COPD patient who also has bullae clearly seen here. Bulla are usually very thin walled and the walls of the bulla will not be seen, but it will leave indentations like this which show that it is a rounded hyperlucent area, and it also has a flattening of hemidiaphragm, a minimal tubular shaped heart and all. The other common yet life-threatening hyperlucency is a pneumothorax. The most characteristic and definitive sign is the presence of the visceral pleural line. This is the visceral pleural line, which is the outer, the layer covering the lung, and beyond this line, the vessels will not be seen crossing it. So this will differentiate a pneumothorax from artifacts like skin folds can also appear like lines, and even the scapula sometimes will appear like a line if not looked at carefully. So in this side, scapula appears here, but vessels seem running beyond this point. So obviously it is not that. But here the patient has a pneumothorax. Coming to the white lung, it is the most confusing part of the X-ray actually. Before calling something as a lung lesion, the organ of origin of the opacity is very important. It could be on the chest wall, or from the pleura, or from the lung, or it could be from the, that's chest wall, lung, or pleura. These are the most common causes of opacities which appear inside the lung field. Here, characteristically in pleural lesions, it will have an obtuse angle with the chest wall, like this. It will be like a D shape. In lung lesions, they may have this angle will be an acute angle. But in cases of a posterior loculation, it will appear like a rounded opacity. For example, say here, that will appear like this. But for that, a lateral X-ray would help. And when it comes to a lung opacity, we need to see if that opacity is due to pathologies involving the alveolus or the interstitium. Those are the two common things that are going to be involved in the lungs. In case of alveolar involvement, the opacities will be fluffy, ill-defined, and when it is very dense, it will appear like this, like lobar consolidation and all. Interstitial opacities may appear like lines, or like nets, that is reticular opacities, or nodules. Chest X-ray is a two-dimensional projection when it is projected posterior to anterior, and this linear opacity is pointing towards this line of projection. That is, when it is seen in the end-on view, it will appear like a nodule. Then what is consolidation? The basic English meaning is the process of being united, that is getting together. Inside lungs, it is represented by replacement of alveolar air by substances that can be anything: fluid, blood, pus, cells, or other substances like in alveolar proteinosis, there will be hyalinous substances. That get together and appear like a solid radiographically. The cause depends on the disease process underlying. Lung opacities have certain patterns that will help in going about the diagnosis. There are a few radiographic patterns that will help differentiating. The common things that will characteristically tell these are the bat wing distribution, that is perihilar opacities, that is characteristically seen in pulmonary edema, and the reverse bat wing sign, that is the radiographic inverse of the bat wing, that is seen in organizing pneumonia, chronic eosinophilic pneumonia and all. According to the distribution, we usually divide the opacities into focal or diffuse. In diffuse, it could be diffuse patchy, that is opacities which are not congruent with each other. It could be scattered, which is seen in pulmonary edema, ARDS, tuberculosis, and disseminated infections and all. It could be a focal patch. Focal infections, lung masses, tuberculosis, Even pleural effusions can appear like this. The description of these lesions will help in differentiating among these. For example, if it is a loculated pleural effusion which is posterior in position, it would be a well-defined rounded thing. But here it is fluffy, ill-defined, so it points more towards the consolidation. In masses, it could be either in benign masses, it could be well-defined, rounded, or in malignant, it will be spiculated and all. So such descriptions would help in differentiating between all these. Or the opacity could be lobar involving the whole lobe. Here the right upper lobe is entirely involved, and this also shows the bulging fissure sign. This could indicate consolidation of the right upper lobe alone, but it could be due to anything from pus or from secretions or fluids or anything. It could even be due to collapse, but collapse is less likely because there is no signs of volume loss and all. The next pattern is segmental. The opacities could involve a particular lung segment alone. That could be seen like this in pneumonias or in segmental collapses or in tumors obstructing a particular segmental bronchi. Segmental collapses may be present. Such obvious findings we will appreciate easily actually. But while interpreting an X-ray and calling an X-ray normal, it will be a very difficult part, especially even for radiographers and even for radiologists and pulmonologists. But while interpreting an X-ray, these are the common things that pose challenges. Technical factors, anatomical factors and variants, artifacts, lesions in hidden areas, and the second problem, piggybacking over another finding. Technical causes include rotation, penetration, angulation, position, and degree of inspiration. Rotation occurs when the patient is not perpendicular to the X-ray beam and turns to his or her right or left side. So lung fields appear darker on one side and brighter on the other, as seen here. Here the right lower zone appears more opaque and the left upper zone appears more hyperlucent. We may even think of the vascularity is practically not seen here. We may think of it as a pulmonary oligemia and think of even pulmonary embolism also. This is just a simple case of rotation to the left. How to define rotation is take the spinous process and measure the distance from the medial end of each clavicle to the spinous process. If they are equal on both sides, the film is good. If the side in which the distance is more is the side to which the patient has rotated, and the side of to the side of rotation, for example, if the rotation is to the right, the whole of right lung field will appear darker. So we should keep that in mind while reading an X-ray. For example, a speck of consolidation may even disappear due to rotation. In this picture, the trachea seems to be deviated to the right and the mediastinum seems to be widened, but this is characteristically rotated to the right. This is actually a normal X-ray. If this is not noted and we go on evaluating, take CT unnecessarily and expose the patient to a lot of radiation. In such gross rotations, we can even ask for a repeat X-ray instead of going for next imaging modality. But in this X-ray, there is true widening of mediastinum and there is no rotation. This is a case of a right paratracheal mass. This rotation can also cause false sense of blunting of costophrenic angle, and we may think of presence of effusion and all. Okay. Next is the degree of inspiration. A good chest X-ray PLU is taken in inspiration, which is marked by 8 to 9 posterior ribs anteriorly, and 8 to 9 posterior ribs and 5 to 6 ribs anteriorly. Here, the vascular markings appear prominent, and there appears to be a consolidation or airspace opacity in both lower zones. but this is just an expiratory fill because there is just 3 ribs, 3 anterior ribs noted here. The same X-ray taken in inspiration doesn't show any significant pathology at all. Next, an underpenetrated X-ray makes everything look whiter and a normal vasculature appears extra opaque, and an overpenetrated one may obscure tiny lesions and make the lung look emphysematous and sometimes even like a pneumothorax. Adequate penetration is defined as when the intervertebral discs are just seen and the contour of the left hemidiaphragm is seen running till the spine. Anything beyond this, anything darker than this is over penetration, and whiter than that is under penetration. This image shows what penetration can do to various densities in X-ray. For example, this has actually 5 different densities in this image. When it is over, that is more X-ray beams are passed, we can hardly define one or only 3 of the densities, and the other 2 have disappeared. And when it is under, we cannot appreciate the differences at all. So such drastic changes we may not be able to appreciate in chest X-ray, and we will actually not know what is inside. In this we can find out. Okay. Next is the angulation. This is commonly seen in ICU setups, where patients will be very sick to stand up for a chest X-ray PA view, and X-rays will be taken in a semi-recumbent position. Here, the heart gets closer to the X-ray source relative to the lung and appears larger, imitating a 𝐑𝐚𝐣𝐚𝐫𝐢. Normally angulated X-ray can be identified by the presence of medial end of clavicle over the 3rd or 4th rib. For example, this is the first posterior, second posterior, third and fourth posterior rib. The clavicle should cross the 4th posterior rib. That is the ideal angulation. In this, the clavicle is crossing the 2nd posterior rib. So it is angulated like this. It has a lordotic angulation. So the X-ray comes nearer. For example, I will just show you a small demo. I am holding this hand here. If my hand is closer to the X-ray beam, the source, it appears larger. When it goes nearer the film, it becomes smaller, and you could appreciate the contour being sharper. If it is near the source, it is large but blurry. This is actually the reason why we take a chest X-ray PA view for lungs, because lung majority volume is located posteriorly. So when we have the posterior facing the X-ray source, that will appear larger and lung lesions will appear larger. Moving on to anatomical factors, the vessels of lower zones normally appear more prominent than the upper zones due to the effect of gravity, and sometimes the apices may even appear avascular as seen in pneumothorax. This may be obliterated in patients who are supine and AP views are taken. In this X-ray, there seems to be a nodule in the right lower zone, which one may consider as a solitary pulmonary nodule and evaluate for lung cancer with CT and all. But this is just the shadow of the nipple. Such nodular opacities in lower zones should be seen with care. Such can be confirmed by keeping a radiographic marker over the nipple and retaking the X-ray instead of going in for CT. Azygos fissures may be seen like this. Sometimes we may mistake it for a visceral pleural line of pneumothorax also. So that should be kept in mind. Here we could badly see the vessels running into it. If clinically relevant, we may even take a CT if needed. The CT of the same patient showing the azygos fissure with the azygos vein and azygos lobe. Air shadows under the right hemidiaphragm. It can normally in under a left hemidiaphragm, the fundus air shadow will be present, but if it is present on the right side, it could indicate a hollow viscous perforation. a situs inversus with the fundus of stomach on the right, or when large bowel is seen like this. This is called the chilaidity sign. Here horstrations can be noted. Here nothing needs to be done actually. And then lesions tend to be missed when they are located in one of these hidden areas, because in all the grey colored part, when I showed you in the beginning, it will appear like that, just a background of black with white vessels running into it. But in these areas, soft tissues will merge a lot and will hide a lot of things. This X-ray shows a retrocardiac opacity that could be easily missed when not looked at in detail. It is actually retrocardiac sail sign, this triangular opacity that indicates a left lower lobe collapse. In another instance, this PA view is practically normal, appears normal, but there is a left lower lobe opacity here. In lateral view, this is called the spine sign actually. Normally in lateral views, the spine will become progressively more radiolucent as it goes downwards, but here it is not there and the opacity is seen. This could be missed, and in cases where it is clinically relevant, and in such cases we could even hear crackles or something in the base of the lungs. So we could go for a lateral X-ray, if needed a CT chest. A wide range of artifacts may also be seen in chest X-ray. In this, on a first glance, this X-ray shows something like a visceral pleural line here, indicative of a loculated pneumothorax, but when it is seen closely, there is a gross rotation of the film, and the line outside could be traced laterally outside the rib cage, like a skin fold. This patient with its rotation corrected appears normal. Such artifacts could easily muddle us when not seen with care, and sometimes the X-rays may not be of such good quality also. When such X-rays appear like this, we will get confused. This is a peculiar case. When we look at the top right of the X-ray, there seems to be subcutaneous emphysema like thing, and right upper zone airspace opacities, which could mean tuberculosis with complication and all. But it is actually the patient's own hair, her jadai. To conclude with chest X-rays, always look before you leap to a diagnosis. Look at the patient, look at the quality of the X-ray before you label lesions, and take into account factors like hidden areas, artifacts, and then diagnose a patient with a disease or say it is normal. I thank Dr. Vignesh sir and Rajarajeswari team for this wonderful opportunity. My seniors, colleagues and friends to have patiently listened to my talk. Please do continue your support. Have a good day. Thank you.